There's just patients everywhere. Must be an overwhelmingly frightening scene for patients as well as medical staffs when casualties like this occur.
Jesse, hang a unit, then right up to the OR.
She shot?
No, looks like she got trampled. Unresponsive in the field, 3 more in the rig.
This happens when a person is knocked down and stepped upon by a crowd, often during stampedes, mass gatherings, concerts, sporting events, or evacuations. There's blunt force trauma from repeated foot strikes, crush injury if the body is pinned against the ground, walls, or other people, and asphyxia and hypoxia. If chest expansion is restricted by pressure, often called traumatic asphyxia, there could be fractures, dislocations, and concussions, or internal bleeds.
Hey, Giovanni, got a possible blunt head trauma here. Pupils are good. Strong pulses. Okay, assess for blunt head, chest, belly.
With who?
Anybody.
We could use the butterfly ultrasound here for checking free fluid collection in the chest and abdomen.
How we doing?
Head's above water so far.
Anything about the shooter?
Haven't heard, but I'll try and get an update.
Jake?
No. But I got his mom on the landline. Told her to call both of us when she reaches. Okay.
Your own son coming in as injured due to a gunshot wound would be a frightening experience for any doctor.
Yep.
1 for pink and 1 for green. On it.
I'm sorry, all press need to stay in the waiting room.
2 minutes. The public needs to know.
Front of the hospital.
What's this? Response to pain only, thready pulse, chest wall contusions with blueprints on it.
A classic case of chest wall injury due to the stampede. Weak pulse and altered mentation with only response to pain suggest he is in critical state, likely a state of shock due to internal bleed due to hemothorax, as trauma can rupture blood vessels in the chest wall which could accumulate in the pleural cavity between the wall and the lungs. Or there could be pneumothorax, since there could be rib injuries and the injured rib can puncture the lung surface leading to pneumothorax even if the chest wall seems intact with just contusions.
Yellow here, wheelchair.
Okay, sounds good. You need anything?
Well, I was hoping for Thanksgiving and Christmas off this year. We can talk about it later.
It's difficult to manage holidays in emergency medicine as you have to come to work even if your duty is on holidays, because the ER has to be open every day and every hour, even at days when the rest of the departments aren't open.
For proper chest tube placement, keep going until the last fenestration is intrathoracic.
When inserting a chest tube, we advance it far enough so that all the drainage holes or fenestrations on the tube are inside the pleural cavity and not sticking out in the chest wall. Each fenestration is a side hole in the tube that allows air or fluid to drain. If one of these holes stays outside the pleural space, air or bacteria can travel in or out, hence causing persistent pneumothorax infection or subcutaneous emphysema. The last fenestration is usually near the tip, so ensuring that it's intrathoracic confirms the entire portion with fenestrations is in its place inside.
What?
I don't need you teaching me right now.
You're already an expert.
Read the Mom.
Help other people in need instead of fixating on people who are already stabilized. That's the rule here. Help patients directly or doctors who actually need help from a surgeon.
Doctor, place a horizontal mattress in case you're wondering.
So, she's sealing the chest tube in place with a horizontal mattress suture 3-0 silk. This helps secure the tube and close the incision site. Horizontal mattress suture simply means the needle enters and exits the skin at 2 points, then is reversed and enters and exits the skin at 2 points, and so on. This helps to oppose the skin edges and create a tight seal around the tube, potentially minimizing air or fluid leakage.
Looks like you've got this.
Soak through his pressure dressing. Okay, yeah, we can fix that with Rainy clips.
Rainy clips are small, spring-loaded serrated metal clips used in neurosurgery, particularly during the initial scalp incisions to control bleeding from the scalp edges before craniotomy to open the skull. The scalp is highly vascular, so when a surgeon makes an incision, these clips are applied along the wound edge to compress bleeding vessels and keep the field clear for craniotomy. It's applied with a special Rainy clip applicator and removed later with a clip remover. They stay in place only during the procedure and are removed before closing the incision. Here, the same clips can be employed to stop the bleeding if the pressure gauze isn't working. Rainy clips are small and curved with teeth that grip the tissue without cutting and hence stop the scalp edges from bleeding further.
What are those? We're using the neurosurgeon to clamp off the scalp before opening the skull.
All right, I'll be right back, Sam. Just keep pressure.
You guys are swamp. I got this. Takes a village.
Sylvia? Whitaker? Sylvia. Sylvia, can you hear me? Sylvia, can you hear me? I lost her radial pulse.
From a broken leg?
Well, what did we miss?
I don't know, heart attack, another injury from the car crash?
So the patient is unresponsive and has no pulse. Could be internal bleeding from the blunt trauma since penetrating wounds aren't present. If we could rule this out, we can resuscitate her with fluids or blood.
That's for pulses.
It has an EFAS mode.
Yeah, Doppler is just one feature. It has all the basic features for an ultrasound, resembling a FAST scan. As we know, EFAST is Extended Focused Assessment with Sonography for Trauma, basically an upgrade of the traditional FAST exam to include the anterior chest and pleural spaces for hemothorax and pneumothorax detection. Its purpose is to quickly identify internal bleeding or pneumothorax in unstable trauma patients. Besides pleural space for hemo and pneumo, we also view Morrison's pouch, which is the space between liver and right kidney, splenorenal recess between the spleen and left kidney, pouch of Douglas between the rectum and uterus, or the rectovesical pouch between the rectum and bladder for any free fluid. Presence of free fluid or blood would suggest hemoperitoneum, meaning blood in the peritoneal space. Subxiphoid view also helps us visualize pericardial space for any pericardial effusion or tamponade.
Diagnosis made.
So this is a visualization of the right kidney and the liver, and between them the space is called hepatorenal space or Morrison's pouch. It's filled with fluid that is blood, which is appearing as an anechoic collection here. This suggests hemoperitoneum, which could result from blunt trauma like in this case. Hemoperitoneum in general could be caused by solid organ rupture, which could be liver, spleen, or kidney. But since Morrison's pouch is between the liver and the right kidney, blood from a liver laceration will often pool here first, especially if the patient is supine. So, the injured organ is most likely liver. Less commonly, injuries to right kidney or retroperitoneum can leak forward into Morrison's pouch, but liver injury is the classic cause here.
Blood in Morrison's liver laceration.
Car hit the belly, leg was a distracting injury.
Drill in an IO, I'm gonna get some blood, and then we'll move her to pink.
Again, an intraosseous access comes in handy to quickly access the bony medullary space. It's quick and as effective as an IV. She requires blood products to be given here through an IO.
Just sends another up to the OR. I got room for one more red.
On it.
Didn't make it. Going to peds.
Another red and trauma 1.
Copy that.
The first death so far who died despite resuscitation.
Dana, right. Careful, kid.
I need Rainy clips and a unit of O-neg.
Rainy's left to come down from the OR.
I need them now. Okay.
They're specifically used in the neurosurgery ORs.
Okay, I'll get them. O-neg here.
O-negative blood is given here because the woman is in her childbearing age, and the concern for Rh sensitization affecting future pregnancies is high if the more available O-positive blood is given.
Here you go. Thanks. We need EVS with the mop.
Not much blood, but a big rush of air. Got trampled, collapses lung.
So the mechanism of formation of a pneumothorax here due to stampede involves rib fractures. The fractured rib punctures the lung surface, leading to accumulation of air inside the pleural cavity. Decompression of pneumo would result in a gush of air. Now, if the defect opens during inspiration and closes during expiration, it would act as a one-way valve leading to progressive accumulation of air inside the pleural cavity, which we call tension pneumothorax. Since it's a life-threatening condition that can cause cardiogenic shock and lung collapse, also called atelectasis, we have to decompress it immediately using needle decompression or chest tube or a pigtail.
Tension pneumo.
Who intubated?
I did.
Mohan is on fire.
This patient required intubation anyway because the stampede would cause restricted ventilation by the chest wall and made the work of breathing difficult. Add to it the lung collapse due to tension pneumo. However, it's important to intubate the patient only after chest tube is in place, or else the positive pressure ventilation from the endotracheal tube would worsen the tension pneumo and could be fatal.
This is coming up.
Okay, great. Slide to pink as soon as there's room.
Got it. Hey, how many ORs available?
1 now, 2 more in less than 5.
Can you take a belly and 1 more chest and...
Most patients either have hemo or pneumothorax or have hemoperitoneum due to the gunshot injuries.
Pray?
No problem.
MCI 21's going to ICU. I'll be back.
Got it.
Red zone.
3 west is full. Take them to 2 south.
I need 0 form, cut 4x4s, and elastoplast tape.
These are just names for the dressing. Zeroform is a type of non-adherent occlusive dressing, basically consisting of fine mesh gauze impregnated with a petrolatum blend and 3% bismuth tribromophenate, which prevent dressing to stick to the wound. We use Zeroform for low exudate wounds like skin graft donor sites, abrasions, lacerations, and burns.
You're here!
In the flesh. What do you got?
Auto versus ped.
We thought it was just a tib-fib fracture.
Then we found an occult liver laceration.
Leg is low priority right now. If she stabilizes with blood, she can wait an hour for the OR.
And if not?
Throw the line, baby.
The blood loss should be replenished, the hemoperitoneum should be drained, and if bleeding continues, surgical options should be explored immediately, like direct repair of the laceration and packing of the liver.
In the OR with the GSW to the chest.
Sweet. Family reunion and post-op.
Whitaker, I'll be right back once this unit's in.
Hey! Good catch, you two.
Come on, Sylvia.
Need some help over here?
Back looks good, no exit wounds.
Red zone! Okay, I'll be right back. Jabati IO. Here too.
Sux is on board.
Succinylcholine, a depolarizing muscle relaxation used for facilitating intubation here. In a mass casualty incident setting, succinylcholine is often preferred over rocuronium, the usual non-depolarizing muscle relaxant used for rapid sequence intubation, mainly because of speed and logistics. The onset of action for succinylcholine is just 45 seconds, while rocuronium takes 60 to 90 seconds, even with high doses. In a mass casualty, seconds matter, so faster paralysis means faster airway control and moving on to the next patient. Also, the duration of action for SUX is just 6 to 10 minutes, while rocuronium lasts for 30 to 60 minutes. Short duration paralysis with SUX means if you intubate the wrong patient while in a hurry or have to reassess priorities and extubate, they can recover breathing faster without prolonged ventilator dependence.
I got it. I'm in, bagger.
They're performing intubation so casually, it's really a sight to behold.
Chad, what are you doing here?
They postponed my surgery.
You can't be in here. Go sit with Harrison in the staff lounge.
Okay.
Now!
Okay. Another one for the morgue. Heading to Pitt.
The sight of patients dying would be extremely overwhelming to those who aren't used to seeing deaths every day. It can cause anxiety, panic, and also post-traumatic stress disorder afterwards.
Hey, buddy.
Did you have your surgery?
No, it got delayed.
Basically, all the elective surgical cases would be postponed, like this case of trimalleolar fracture, which has been stabilized using double splints. The emergency management is done. Surgery can definitely wait. Only the pending emergency cases or the cases from the ER right now would be operated, that too after triage and assessing which case needs emergency surgery the most out of all emergency cases.
That's one unit in.
It's really painful to just hold the IV drips like that until they get finished.
Her pulse is stronger, but she needs more blood.
Not today. Only one unit if the pulse picks up.
Just an okay pulse volume is good to go with. We gotta save blood for more needy patients.
We're already rationing our blood supply.
What if we run out?
I wanted rainy clips.
Oh, me, thank you.
I thought you left.
All hands on deck, right?
Is there any word on Omar? He's this woman's deaf son, teenage boy shot in the chest.
Kid got lucky, missed the aorta. He should pull through.
A gunshot wound to the aorta would have been disastrous. It's almost always rapidly fatal unless the patient gets immediate surgical intervention. The aorta is the largest and highest pressure artery in the body. A penetrating injury through and through like a bullet would cause massive hemorrhage within seconds to minutes. Blood loss can be external if wound is open or internal into the chest if thoracic aorta is involved, causing hemothorax or cardiac tamponade if the root of aorta is involved before the aorta ascends. If the abdominal aorta is involved, it would cause massive retroperitoneal hemorrhage. Exsanguination, meaning loss of more than 40% blood volume, occurs in under 1 to 2 minutes in many cases. The patient would typically either be brought dead or have profound hypotension and pulselessness, requiring either open thoracotomy or laparotomy and direct repair, or endovascular stent graft. Survival rate would be less than 30%.
Oh, that's amazing. Well, her name is Sylvia. Would you please tell her about her son when she wakes up?
What are you using the... What's this?
Unresponsive, even to pain. No GSW, strong pulse, but tachycardic and diaphoretic.
Sounds like a case of blunt trauma with profound shock, suggesting some internal hemorrhage. Or I could think of head trauma too, in this particular setting of mass casualty.
Looking for internal hemorrhage. Fast negative.
Help me, Roller.
Tim, Amp D50 now.
This means 1 ampule of 50% dextrose solution, a concentrated IV sugar given to rapidly treat severe hypoglycemia. Basically, it's 50 grams of glucose per 100 milliliters of solution. We're so caught up in just thinking of trauma and bleeds and miss out the simple diagnosis of hypoglycemia. Hypoglycemia definitely does present with neurogenic symptoms due to sympathetic activation like tachycardia, sweating, and tremors, while neuroglycopenic symptoms caused by depletion of glucose in the brain would be confusion, lightheadedness, and loss of consciousness, and could even lead to seizures or coma and death. Hence, hypoglycemia is more dangerous than hyperglycemia.
Seriously?
Look, glucose monitor. She's diabetic and probably hypoglycemic.
So check a blood sugar.
No time for that.
Doesn't take much time for a blood glucose strip.
Still could be head trauma if it's decay, you're making it worse.
Diabetic ketoacidosis could also present with dehydration, leading to all the symptoms here, and would be treated with insulin, the exact opposite of what's been given in 50% dextrose. We definitely don't have time for blood or urine test for ketones here.
My spidey sense is telling me she took her morning insulin, but she skipped lunch.
This is one of the most common reasons for hypoglycemia. Using insulin or insulin secretagogues like sulfonylureas or meglitinides but not taking lunch, people wouldn't skip medications due to fear, but wouldn't bother skipping lunch, and that leads to insulin-induced hypoglycemia.
She's in a coma from low blood sugar. Will you look at that? These are healing hands.
Too bad they're so tiny.
Hello, what's your name?
Dawn?
That's a dramatic improvement here. Simple things like correcting blood sugar can literally save the life of a patient. You don't have to do complicated surgeries to save life in medicine.
Where am I?
Pittsburgh Trauma Medical Center. You dropped your blood sugar, but you're gonna be okay.
Guess you don't need me here? Don't even say it.
Let's get her to yellow.
She immediately went from almost being in the black zone had she lost her pulse to being yellow after being stabilized, and now doesn't need emergent treatment and can wait down the line.
What happened?
There was a shooting at Pitt Fest, but you're safe now.
Whatever you can spare, thanks.
MCI 33 to yellow for monitoring. What are you doing?
Ran out of laryngoscopes, no time to autoclave.
Laryngoscopes are used in intubation to visualize the vocal cords before putting the endotracheal tube in between them. As we discussed in previous episode breakdowns, in normal ER settings, we used a video laryngoscope with a camera at the tip, where we could see the cords on the screen. This is the traditional rigid laryngoscope here, where we have to align the laryngoscope to have a direct line of sight at the vocal cords.
Oh, man.
Almost out of chest tubes, too. More coming from breast pain. Running very low and no neg.
Perfect storm.
Dr. Langdon is portrayed here as a personality who thrives in these emergency situations. High adrenaline, high energy, fast, quick. ER is really a good fit for him, and this hyperacute state has likely caused him to use benzos to control him from overshooting.
Do you feel anything, Grayson?
No pain.
She's holding the Rainy clip with the Rainy clip applicator. Rainy clips, usually used in neurosurgery after scalp incision before craniotomy, is used here to stop the scalp bleeding from the lacerated edges. They have teeth that grip the scalp tissue, sealing off the bleeding arteries tight and stopping the bleeding.
Just a lot of sadness for the world we live in.
I hear ya.
Any room in the inn?
What's her story?
This is Dawn. No trauma. Insulin reaction. Responded to D50.
D10 at 100 an hour?
After the initial 100 milliliters of 50% dextrose IV push, 10% dextrose at 100 milliliters per hour is a common adult maintenance rate for hypoglycemia. In pediatrics, infusion rates are adjusted by weight and glucose infusion rate.
Perfect. Oh, and I borrowed your butterfly. It's on the gurney.
So just like that. Yep.
What are you doing?
Treating a patient.
Rainy clips. Clamping off a bunch of sub-Q bleeders.
Good work. Keep it up.
Yep, perfect. That's it.
I need suction.
We don't have any.
Too many secretions, I can't see shit.
Visualizing the vocal cords is important here with rigid direct laryngoscopy that demands a direct line of sight. Secretions would be a problem, and so would airway swelling or bleeding.
Here, wipe it out with 4x4s.
Are you kidding me? You guys have a fiber optic laryngoscope?
Mass casualties require rapid airway turnover. We're managing multiple patients, sometimes in seconds. Video laryngoscopes and flexible fiber optic scopes take longer to set up, position, and clean between patients. We might have few video scopes or fiber optic units available, and batteries, light sources, and sterile covers can run out. So, the priority is getting oxygen into as many viable patients as possible, not performing the most elegant intubation, so we go for traditional rigid direct laryngoscopes.
Yep, just a rigid glide scope deal. Except we don't have any room for it, so just pull out one bag for a minute.
When did this guy last eat?
We never know down here. Sneak in there.
Team cricoid pressure. If he vomits, we're fucked.
Doctor?
In cases of difficult or failed endotracheal intubation, we need to perform cricothyrotomy. We learned about it in one of the previous episode breakdowns as well. It simply means making a surgical incision through the cricothyroid membrane to establish an airway. It's done when intubation is impossible and devices like laryngeal mask airways are insufficient for ventilation. Basically in a cannot intubate, cannot oxygenate situation.
Hold on. Oh yeah, this is a tough one. Yeah, this one looks tough.
No shit. Prep the neck.
Hold on, okay?
Yeah.
Come over here and just give me a chest compression.
CPR? Did we lose the pulse?
No, just give me one good push.
This is a passive laryngeal elevation technique used when the glottic view is poor, especially in trauma. By giving a brief downward push on the chest via chest compression, you create a sudden increase in intrathoracic pressure, which can move the larynx upward and anteriorly into the line of sight for direct laryngoscopy. The pump we gave via chest compression also causes transient air movement upwards into the trachea. We'll see air bubbles emerging, and we put the tube in from where the bubble came from, which has to be from between the vocal cords.
Yep, okay, give me the tube. And do it again. Okay. I think I am in. Bag him.
Check the end tidal.
The trick worked here. Now, if the end tidal CO2 color changes from purple to yellow, this means the CO2 is present in exhaled air, which means the endotracheal tube is correctly placed in the trachea and not the esophagus.
Yellow, we're good.
How did you do that?
Bubble intubation. You gave the compression and followed the air bubbles up.
Exactly like we described before. The series portrays different techniques of the same procedure, that is intubation during difficult visibility. Even retrograde intubation was also shown earlier in a case which also had difficult visualization due to the ongoing tonsillar hemorrhage, where a guide wire was passed upwards through the cricothyroid membrane via needle puncture and out through the mouth. Then this wire was used as a guide to insert endotracheal tube without fail into the trachea.
More than one way to tube a cat.
Coming through.
Robbie, now, please.
Wow.
What's that?
Anything from Jake?
Intubated, chest tube, but massive subcutaneous emphysema.
Massive subcutaneous emphysema after a chest tube with intubation usually means that the positively pressurized air that's being pushed into the lungs is still escaping from the lung into the subcutaneous tissues, meaning your chest tube isn't actually resolving the air leak.
Air from the chest is leaking under the skin.
Now, this could be due to malposition or blockage of the chest tube. As pointed out before, if the tube side holes or fenestrations aren't fully in the pleural cavity, for example, last fenestration is sitting in the chest wall or subcutaneous tissue, air from the lung leak will track into the skin instead of venting out. Kinked, clamped, or blocked tube can also cause the same issue. If the pneumothorax defect is large, it can overwhelm the drainage capacity of the tube, and hence every positive pressure breath from the ventilator forces more air into the pleural space and through tissue planes rather than through the tube, causing subcutaneous emphysema. Subcutaneous emphysema itself is rarely directly fatal, but it's a sign that the airway and chest aren't sealed. For management, we first check chest tube function and confirm all fenestrations are intrathoracic, the tube is patent, and there are no kinks. We could consider adding another large bore chest tube at second site if air leak is huge. If bronchial or tracheal injury is suspected, we send the case to OR. Decompression of the emphysema is only done if the swelling is compressing the airway or has tracked into mediastinum causing pneumomediastinum or retroperitoneum causing retroperitoneal emphysema, causing significant patient distress including hemodynamic instability.
Loosen the pulse.
What do you think?
Tamponade from pneumomediastinum.
So subcutaneous emphysema or the pneumothorax itself can track into the mediastinum or retroperitoneum because air tracks down loose connective tissue planes. If air leaks into the mediastinum, we call it pneumomediastinum, which can cause cardiac tamponade like physiology, sometimes called tension pneumomediastinum or pneumopericardium with tamponade effect. How this happens is pneumomediastinum or air in the mediastinal space causes increase in mediastinal pressure. This directly compresses the heart, great veins, and trachea that are inside the space. This impairs venous return to the right heart, and there is low cardiac output causing hypotension, tachycardia with low volume pulse, and distended neck veins. This is called obstructive shock, just like in tamponade or tension pneumothorax where the heart or the great veins are also compressed but due to increase in intrathoracic or pericardial pressure. Now, to release the subcutaneous emphysema, we make blowhole incisions, which are 2 to 3 centimeters, skin incisions in the supraclavicular area or the infraclavicular area. The incision is made through skin and subcutaneous tissue down to fascia and left open or with a drain like a Penrose drain or corrugated drain inserted in the incision to keep it open.
About to cut blowhole incisions to release the air.
Do it. Infraclavicular. Yep. Pulse is coming up. Nicely done.
This means the subcutaneous emphysema and the pneumomediastinum underneath have been decompressed. The obstruction to the heart and great veins have been relieved, which means the preload and the cardiac output would increase, resulting in a high volume pulse than before.
Okay, send him to cardiothoracic ICU.
We'll get you pain medicine. A nurse will be by soon.
Hey, where'd this guy go? Which patient?
MCI 28 arm injury who refused treatment.
Maybe he left?
There's a gunshot wound. Hey! Hey, what the hell are you doing?
Fine, leave me alone.
You can't do that.
Back off.
We need security in here.
Hospitals often have strict policies restricting recordings to protect everyone's privacy and safety. Patients recording in hospitals without permission is absolutely contraindicated in all cases. There are privacy and confidentiality laws that protect patients and staff, and unauthorized recordings can breach HIPAA in the US. Sometimes patients can ask for permission, or recordings can be allowed in certain situations with consent, but it's rare.
He's hypertensive.
Nice moves, Slick.
What happened?
I think this guy stole a victim's hoodie and faked an injury to get inside. He's probably ordered.
Asshole.
Hey, wake up, you faker.
She's applying a sternal rub to check if he responds to pain. For those who haven't experienced a sternal rub, it's pretty painful. There are other ways of painful stimuli like trapezius squeeze, supraorbital pressure, comes in handy especially if you're working in the neuro ICU where you have to consistently record GCS of patients.
Yeah, response to pain. Her low blunt head trauma goes to pink. Soft restraints, 6 hours observation.
Right to the hub. Be right back.
I'm fine.
Great, you can give a statement to the cops. Get them out of here.
Where's my phone?
Oops. My bad.
There are patients literally dying, and people are concerned about recording and displaying it in news for some views. Pathetic stuff, really, and this gets annoying too, in high tense situations like this.
Chest tube, please.
We're out of chest tubes.
What the hell? You could have told me that before we started.
I didn't know.
I already made the incision. Now what am I supposed to do?
How about this?
An ET tube.
A tube's a tube, and if you inflate the balloon, it won't pull out.
Fine, set up a thoraceal.
Desperate times call for desperate measures. Gotta use whatever we have to treat the patient, even if it's unorthodox and not usually recommended.
Out of those two.
Oh, for the love of God. Hearing bag? How am I supposed to connect to that?
Christmas tree adapter. It'll work.
So, an ET tube to the chest connected to a Eurobag via a Christmas tree adapter. That's a creative way to solve the issue. In resource-limited settings like this, a Eurobag can be repurposed as an underwater seal bottle to allow air or fluid from the pleural space to escape but prevent backflow, which is the key function of an underwater seal. For this, we gotta fill the Eurobag partially with sterile water to create the water seal. The Christmas tree adapter can be used as a connector between the ET tube and the Eurobag tubing to secure the setup. The bag acts as a one-way valve, where air escapes from the chest, bubbles through the water, but air cannot return. Lastly, the bag should be kept below the level of the chest to maintain proper drainage by gravity.
This is all very unconventional.
No, this is genius.
Oh, and 4 of ANSEF. Sorry, I forgot the ANSEF.
ANSEF is the brand name for cefazolin, a first-generation cephalosporin used to prevent open wound infections due to the bullet here.
Mel, I need you to reassess, please, now.
Sylvia? Her pulse is weak and thready. She's bleeding out from her liver lag. I need ONEG!
ONEG's gone, honey. Glory's got more flying in. Incident command, what's the ETA on our blood?
The patient's gonna have to get by with a liter of saline.
No, she needs blood, not crystalloid.
The patient with the liver laceration is actively bleeding and requires blood transfusion rather than just crystalloids like normal saline or lactated ringers for resuscitation. Crystalloids only replace lost fluid volume but do not carry oxygen or replace lost red blood cells. In severe bleeding, especially from a major organ like the liver, the patient loses both volume and oxygen carrying capacity. So blood transfusion replaces volume and restores oxygen delivery by providing red blood cells. Also, large amounts of crystalloids alone can cause dilutional coagulopathy and can worsen bleeding. Early blood transfusion, ideally balanced with plasma and platelets, is critical in hemorrhagic shock.
Can she go to surgery?
All right, she's next to go. As soon as we get an open OR.
She's not gonna last that long. Dr. Robbie. Dr. Robbie! Dr. Robbie, we're out of ONEG, but I'm ONEG. Can I donate? But I need it now.
What is our blood status?
Just use the last units of ONEG and Opasmor flying in.
ETA?
Less than 10?
Some patients are not gonna last that long, and I'm sure there are other O-neg donors that probably work
It
here.
would take hours to screen for HIV and hepatitis.
Well, I have neither, and I donate all the time.
Before blood is stored in a blood bank and released for transfusion, it is rigorously screened for several infectious agents and compatibility tests to ensure safety. It's checked for infectious agents like HIV 1 and 2, hepatitis B and C, syphilis, human T-cell, lymphotropic virus 1 and 2, and so on.
Please.
If the patient's going to die before they get to the OR, then the benefits outweigh the risks.
My man.
It's better to transfuse a non-screened blood than to not transfuse blood at all to an actively hemorrhaging patient who has already collapsed.
All right, kid, roll up your sleeve. I'll meet you in 7. Listen up. Central 789 is now the Blood Donor Center. Anyone who's O-neg or O-pos, we need you to donate now. Hands where I can see them. Okay.
As said before, the universal donor blood group is O-negative because it has no antigens. But it's very rare and hence has limited supply. So we go for O-positive blood, which is commonly available, doesn't have A or B antigen, but still has the Rh or D antigen. The catch is that if you give Rh positive blood to someone who is Rh negative, they'll become sensitized and make anti-D antibodies. In most adults, this is only a long-term concern, and the benefit of transfusion outweighs the risk right now. But in children under 13, they could be affected by the sensitization in their adulthood. Also, in females of childbearing age, she could develop IgG antibodies against Rh factor. And in a future pregnancy with an Rh positive fetus, those antibodies could cross the placental barrier and attack the baby's RBCs to give rise to hemolytic disease of the newborn. So, considering these things, in an emergency setting, we give everybody O positive unless it's a female in her childbearing age or children under 13, in which cases only we provide the O negative.
Let's do this.
You two work here, right?
Yes.
Can you tell me how my mom is? Her name's Patricia Gregory, or Trish. She was shot in her arm.
We're here to help. 1 second. Bear with us.
Can I have your attention, please? My name is Kiara Alfaro. I'm an emergency department social worker. This is Lupe Perez, one of our ward clerks. I know you all want information about your friends and family. In order to help you, we have a QR code you can scan for our patient identification website.
Any info about their beloved is such a relief for family members who don't even know if they're still alive or not. Reassurance is key here, and it's very important for the mental health of the family members.
Cell phones are down, but you can log on to the hospital guest Wi-Fi. That information is on these papers we'll distribute around the room.
Once you log on, send us the name and birth date of whomever you're concerned about.
If you could tell us what they were wearing, upload photos, pictures of tattoos, piercings, anything to help identify them would be useful.
If we get a match, we'll let you know.
So, there's likely going to be a dedicated team who would relay information about the patient's progress to the respective family members.
We're setting up phone chargers, water, snacks, and if anyone needs to change clothes, we've got paper scrubs coming.
Give us some time. We're doing everything we can to help get you the information you need.
There you go, there you go.
Next!
How's she doing?
Yeah, 500 of saline in. She's barely with us, Mo.
Okay, well, this unit of whole blood should help.
This is the intraosseous needle drilled in the greater tubercle of the proximal humerus. Other common insertion sites include proximal tibia in the anteromedial surface, just below the tibial tuberosity and distal tibia.
Yeah, see if you can find a pressure bag.
No, much faster if I just squeeze it in myself.
Need some help with an airway?
What is it?
GSW to the neck with expanding hematoma and distorted anatomy. Can intubate him, probably hit the carotid.
Okay, I'll do the airway.
Gunshot wound to the neck can cause an expanding hematoma in the neck. The rapidly increasing swelling can compress airway, that is trachea and larynx, major vessels like carotid and jugular, and nerves like vagus and recurrent laryngeal nerve. Here there's likely a carotid artery injury, which causes massive bleeding into soft tissues leading to hemorrhagic shock. Here, the distorted anatomy means the traditional intubation landmarks are obscured. The neck swelling makes direct laryngoscopy, video laryngoscopy, and even supraglottic airway placement difficult. And if we delay to somehow secure the airway, hematoma can cause complete airway obstruction within minutes.
Give me a 6.5 and a bougie.
I got the bleeder.
The hematoma from the carotid injury is killing the patient in two ways. It's obstructing the airway and it's causing massive hemorrhage. Both of these issues require immediate management.
Foley catheter with a 30cc balloon.
He's likely going to control the hemorrhage from the carotid via Foley balloon tamponade. Here, the Foley catheter with the balloon is inserted directly into the bleeding carotid. While inside, the balloon is then inflated to 30cc to tamponade and press the arterial injury. This hopefully stops the bleeding from the artery and buys additional time for the patient to get the definitive vascular surgical repair of the artery in the OR. This is done in emergency trauma cases when vascular clamps or repair aren't immediately possible.
Are you donating?
Oh, neg, yeah.
It's too bloody to see a bougie.
Not for this three-step process. Step 1, scalpel. Step 2, finger. Step 3, bougie.
He's taking care of the airway and probably going to do a cricothyrotomy. The three-step process he's describing is the scalpel finger bougie cricothyrotomy technique. Here, first a horizontal incision is made through the skin and cricothyroid membrane. We insert our finger to dilate the passage and confirm entry into the airway. Then, we insert a bougie into the trachea through the opening, then railroad or slide the endotracheal tube over it. This is a can't intubate, can't oxygenate scenario to get the fastest surgical airway possible.
Okay, railroad in the tube. Good, that's far enough.
So the ET tube has been successfully passed through the cricothyrotomy incision and into the trachea to access and secure the airway. A 6.5 millimeter endotracheal tube is used here because it's small enough to pass through cricothyroid membrane in an adult.
Okay, bag him.
Okay, dressing off. Foley's in. Blow up a balloon.
30 cc's in.
The Foley balloon tamponade has also been applied and it has successfully stopped the bleeding. Now the patient can be safely transported to the ER with the airway secured and the bleeding controlled temporarily.
Clamping. Look at that. Dry as a bone.
Room for another red.
Dr. Walsh, you have an OR for a head and neck case, MCI 48.
We've got 16 ORs up and running. We've got room for one more.
Liver light came back after a second unit. Needs an X-lap.
X-lap means exploratory laparotomy. Here we cut open the abdomen and apply perihepatic packing with laparotomy pads to tamponade the bleeding. Definitive repair is done later once they're stable, which include repair of the laceration with hepatography or suturing of liver parenchyma and segmental resection of the liver if necessary.
Turning over 2 ORs now. Send them up.
Where the hell did Mel go?
I don't know, but she needs to get back to yellow.
That's 2 grams of Ansef.
Great.
Dressing. That looks good. The bleeding stopped. Can you wiggle your fingers?
Ma'am, can you move your fingers for me?
Distal neurovascular status is the assessment of nerve and blood vessel function distal to an injury or fracture to ensure that circulation and nerve supply are intact. We basically palpate distal arterial pulses like radial pulse here for arm injuries or dorsalis pedis for leg injuries. We also check for sensation like pinprick sensation and motor function like asking patient to move their fingers or toes. This is very important because this can detect proximal vascular or nerve injuries to quickly guide surgical treatment or even detect compartment syndrome, which is a surgical emergency.
Okay, does it feel the same on both sides? Great, how's the pain? Well, the bullet probably went through the 2 forearm bones, but there's no damage to the nerves or arteries, so that's a good sign. You're gonna be okay.
I'll find you some tissues.
Experiencing a traumatic event like this surely causes a lot of mental health issues. These include acute stress reaction, acute stress disorder, and post-traumatic stress disorder, where we have flashbacks and vivid memories of the events, nightmares, anxiety, avoidance, and so on. Long-term, this could cause generalized anxiety disorder, panic disorder, major depressive disorder, survivor's guilt, which means feeling guilty for living when others died, and adjustment disorders. So, we gotta provide early psychological first aid with reassurance, trauma-focused cognitive behavioral therapy, and support systems like family, peer groups, and survivor networks for these patients.
Robbie, blood's arriving.
Oh, right on.
Eviscerated bowel. Fresh ABD and saline.
An eviscerated bowel means the abdominal contents, usually loops of small intestine, are protruding outside the abdominal cavity after a penetrating wound. Here we do not try to push the bowel back in because there is risk of further injury, infection, and contamination. We expose and ensure the patient is on a flat surface, airway and circulation are addressed first. Fresh ABD means fresh, sterile abdominal dressings. Dressings are soaked in warm, sterile saline to keep the bowel moist because dry bowel becomes necrotic and dies quickly. The evisceration is to be covered gently with a moist covering and prepare for urgent surgery, that is, repair.
Okay, back for a sec.
3.375 Zosyn and a sterile dressing.
Can't believe I'm saying this.
Zosyn means piperacillin and tazobactam, high-grade potent broad-spectrum antibiotics that covers all gram-positive and negative bacteria, including Pseudomonas.
Another Christmas tree and Foley bag. How did we run out of chest tubes?
So, this is the Eurobag connected to a Christmas tree adapter connected to the ET tube, which is draining the hemothorax by functioning as a chest tube.
Less than 500 cc's at surgical ICU can take him.
The collection of blood slowed down at 500 cc, which means the patient can be safely monitored in the ICU. If it was 1500 cc's or more, which is the cutoff, it suggests massive hemothorax, and we would have needed surgical exploration with thoracotomy to identify and ligate the bleeding vessel.
These tubes in the chest, they're gonna wonder what the hell we're doing down here, but it was a great save.
Hey, Giovanni, I need you to find Whitaker. Go up to the helipad. We got blood flying in.
Okay.
Stay behind the yellow line between 10 o'clock and 2 o'clock so the pilot can see you the whole time.
Okay.
You got this?
Moving them up as fast as we can.
Awesome. I'm gonna go check out triage.
Copy that.
They find the shooter yet?
Not yet, but we'll find him. Half the county is looking.
What about with her?
Waiting for the FBI to get here.
They find her son?
No, but they pinged his cell phone to the area to shoot him.
I mean, he must be the shooter here. What more indication do we need? Dr. Robbie is going to regret giving the guy more benefit of the doubt and not trying to lock him up sooner, when he had the chance, the time, and the authority to.
She know that is?
He's about to find out.
What's with all these bloody handprints?
That's from people trying to stop us to get a ride in, but we were already packed.
That's an indication that there's going to be much more patience than existing.
Chest, belly, arm and leg, red, pink, yellow, and a lucky green.
Your partner's in bad shape. What's his name?
Rich Stefano.
Hey, Rich. How you doing? You got shot in the face?
No, engine's on the other side. Neck, above his vest. Cheek is the exit wound.
Okay. Come on, red zone. He needs an airway. Come with me. Come with me.
We got to intubate the patient before the airway becomes swollen enough to be completely obstructed.
I got you. We'll get you fixed up.
Hey, what's up with the SWAT team?
It's just a precaution in case the shooter heads this way.
Is that a possibility?
There was some chatter. Are we gonna be safe out here? Should be now.
Focus on the patients.
That's bad news right there. Doctors do need security, or else they themselves have to run for their own lives here.
Focus on the patients.
Only way out is through.
Any idea how many more come?
Incident command is sending all these ambulances back to the scene for more victims. We may not even be halfway through yet.
Jesus, when is this gonna end?
I would just freeze at the thought of a beloved son or daughter or wife being trapped in such an unfortunate situation and would not be able to function and do my job properly. It would be the most frightening thing ever. Thanks for watching. Have a great day. See you in the next one.